this series. So just to give a bit of information while we're waiting, I wanted to tell you a little more about this series. It's part of the Mind Matters education series through the psychiatry department. And our goal here is to bridge the world of addiction research and clinical treatment of addiction. As many of you know, University of Michigan has a robust research enterprise. And you might not be aware that we're actually very well known in the area of addiction research nationally and internationally. So our department and the Addiction Center in particular is one of the leading recipients of NIH funds for alcohol and drug research, with millions of dollars in grants in research, including developing and disseminating new treatments for addiction. And we're in the top 10 of many metrics of research impact in the country. It can sometimes feel like there's a disconnect between the research world and the clinical worlds, between what we do research on and some of the clinical applications of that research. So one of our goals in UMATS is a University of Michigan Addiction Treatment Service, or UMATS, is to provide research-informed treatment. And part of that is also providing expert clinical care and engaging the community and doing educational events about really fundamental questions like what is addiction, what is treatment, what type of addiction treatments work, etc. So we just developed this seminar series to share that information in a public-facing way. And this is a new effort. We're in the third of 4 monthly presentation series for this spring, and we'll be doing more again in the fall. So please give us feedback, whether we're accomplishing our goals, how you receive the information, what you'd like to know that we're missing, and how this may be useful or others or other ways of approaching this. So all of that kind of information is welcome. And in just a minute, I'll do the introductory remarks for the talk. We'll just make sure we give a few more minutes to let people trickle in. Okay. It's 7:05, so I'll officially welcome everyone to the Mind Matters series. Tonight's topic is medications for treating addiction. I'm Ann Fernandez. I'm an assistant professor and director of clinical programming at the University of Michigan Addiction Treatment Service. And UMATS is located at the Rachel Upjohn building off of Plymouth Road in Ann Arbor. It's part of the Addiction Center in the Department of Psychiatry. This educational series has been made possible by the Patrick Gibbons Memorial Fund, which honors the memory of Dr. Gibbons, a passionate doctor who helped many people in pursuit of recovery from addiction. This fund provides addiction education for those in pursuit of recovery and fosters patient, family, and community outreach efforts. A core part of our mission at UMATS is to deliver care that is directly informed by research. With this speaker series, we're hoping to share the latest research on addiction and how it helps to explain how problems related to substance use arise, what makes them continue, and how to break out of the cycle of problematic substance use. We're aiming to deliver this series quarterly, with each talk focusing on different aspects of addiction and its treatment. Tonight, joining us is George Cameron Coleman, MD. He's a clinical assistant professor in the Department of Psychiatry. Dr. Coleman is a practicing physician at UMATS. He focuses on the comprehensive treatment of substance use disorders, tobacco cessation, motivational interviewing, and integrating addiction treatment within primary care. Dr. Coleman received his bachelor's degree in human biology and his MD from the University of Virginia. He completed internship in internal medicine, residency in preventive medicine, and fellowship in addiction medicine at the University of North Carolina, Chapel Hill. He also completed a master's degree in health informatics at the University of North Carolina. Outside of work, Dr. Coleman enjoys reading, nonfiction, hiking, and trail running, watching basketball, and playing golf. Dr. Coleman, thank you so much for joining us. Before we begin, I just wanted to mention The questions can be submitted by clicking on the Q&A button at the bottom of the screen, and there's an option to submit questions anonymously. After Dr. Coleman's discussion, we'll do our best to answer as many questions as possible, and a recording will be available and emailed to everyone as soon as it's available. And with that, I'll turn it over to Dr. Coleman. Thank you.
All right. Good evening, everyone. It's great to be with you. Can somebody just give me a quick thumbs up if you're seeing my slides and hearing me okay? All right. Well, as Dr. Fernandez said, my name is Cam Coleman. I'm one of the addiction medicine physicians here in our clinic at UMATS. I see patients in our clinic in the outpatient setting, and we talk a lot about medication and non-medication treatment options for addiction. So that's what we'll focus tonight's session on. I'll try to give you an overview of some of the common medications that we use for addiction treatment, and we'll make sure that we save some room at the end to address all of your questions. So my slides are, here we go. Some of you may be familiar with this term, MAT, or medication-assisted treatment. And what this is, the idea here is the use of medications in combination with counseling and behavioral therapy for comprehensive treatment of addiction and substance use disorders. So if you hear patients or friends talk about receiving MAT or going to an MAT clinic, what they're likely referring to is a clinic that provides both medication and non-medication treatment for addiction. There are some folks in the addiction world that actually hold the view that medication alone, in some cases, can be sufficient treatment and should not be viewed as secondary necessarily to counseling or therapy. So some folks have recoined this acronym MAT as medication for addiction treatment rather than medication-assisted treatment. But in any case, we offer MAT in our clinic at UMATS, and that's what I'll give you an overview of tonight. We'll start by reviewing some of the common medications that are available for the treatment of alcohol addiction or alcohol use disorder. And there are 3 medications that are FDA approved for alcohol use disorder. They are Naltrexone, Acamprosate, and Disulfiram. I want to point out that all of the medications that we'll cover tonight don't provide a cure for addiction per se, but they can be a very beneficial part of a comprehensive treatment strategy for patients. So that's what we'll review. We'll start with Naltrexone, which has been FDA approved for alcohol use disorder and is considered really first-line medication treatment for alcohol addiction. This was FDA approved in 1994, and it actually works as an opioid blocker. So you'll hear me talk about Naltrexone later in the talk when we also talk about medications for opioid addiction. But it works in patients who have alcohol addiction or alcohol use disorder by making alcohol less pleasurable. So a lot of patients who take Naltrexone will say they just sort of lose the taste for alcohol, or they don't experience the same cravings or urges to consume alcohol that they did before starting this medication. This is a very safe and effective medication for patients, regardless of whether their goal is to stop drinking altogether and to achieve total sobriety, or for those patients whose goal maybe is just to reduce their drinking or cut it back a little bit. We can use this medication in either situation. And patients don't have to have already stopped drinking. They don't have to have gone through detox to be considered for Naltrexone. The dosing of Naltrexone is relatively easy. It's 1 tablet, 50 milligrams once a day. That's it. We don't have to titrate the dose up over time or titrate the dose down at the end of treatment. But it's available as an oral pill, a tablet that patients can take once daily. It's also available as an injection that you would get in the muscle once a month if your preference is not to take a pill or a tablet every day. This is a medication that is metabolized in the body by the liver. So even in some patients with mild liver inflammation or mild liver disease, it's generally safe to start this medication under medical supervision. But for patients with more advanced liver disease and really severe cirrhosis, this may not be an appropriate choice. Side effects are generally mild. I tell patients that maybe 1 or 2 folks out of every 10 who start this medication may have some nausea, some changes in appetite, some difficulties with fatigue. But those symptoms and side effects tend to resolve after the first couple of days. So again, the take home with naltrexone is first line medication, FDA approved since the 1990s, and it really works by having an anti-craving effect or just making alcohol less pleasurable. The second medication that we use for alcohol use disorder is called Acamprosate. The brand name for this one is called Camprol. This is really one that is reserved only for patients who have stopped drinking and whose goal is not to return to drinking. So if folks have a goal of maybe reducing or moderating their alcohol consumption, this would not be necessarily a recommended medication for them because it hasn't really been shown to work in that population. But it works in the brain by helping to mitigate some of the cravings and some of the what we call protracted withdrawal symptoms that can occur once folks have stopped drinking alcohol. Things like irritability, insomnia, and urges that might increase someone's risk for returning to drinking. That's how acamprosate works. It's used more commonly in Europe than it is here in the United States, but we still use it here. Some folks consider a second-line medication and will recommend naltrexone first, but we're happy to offer acamprosate for patients who are interested in this one. It does work. We know that about 1 in 5 patients treated with acamprosate will remain abstinent or remain sober after 1 year, compared to just 1 in 10 treated with placebo. We generally use acamprosate once patients have already successfully stopped drinking and gone through a detox process. We'll typically recommend starting it in that first week of sobriety. It's also an oral medication. It's a pill. It's actually a pretty large pill, a tablet or a capsule, and the dosing is a little complicated. You take 2 of these capsules 3 times a day. So some folks prefer not to take a medication 3 times a day. Some folks would prefer to only take something once a day, but that's the way that acamprosate works. This is a medication that's not a controlled substance. So if patients want to stop using it, they can just stop it. There's no need to taper down the dose. And in contrast to the first one that we talked about, naltrexone, which is broken down in the body by the liver, acamprosate is broken down by the kidneys. So this is one that even patients with severe end-stage liver disease could take safely. But it's one if patients have kidney disease or if they're also on other medications that might affect kidney function, we would want to monitor and check some lab work. Like naltrexone, this medication also has pretty minimal side effects, but some patients may experience some diarrhea, upset stomach, even some jitteriness or some fogginess for a day or 2. Almost always, those side effects tend to resolve during the first week. The last medication that we have for alcohol use disorder is called Disulfiram. The brand name for this one is Antabuse. And this is an older drug. This is one that's been around since the 1940s. It was actually FDA approved for the treatment of alcohol addiction in 1949. And this is one that works in the body by interfering with the way the body breaks down and clears alcohol out of your system. So if you take this medication and then you drink alcohol, it makes you really sick. So it's designed to work as a deterrent. We use this medication in theory for patients who have stopped drinking, who have completed detoxification, and whose goal is not to drink any, whose goal is sobriety. This is an oral medication that's available as a tablet that you take once a day. But again, it's important that you don't take this medication if you've had any alcohol in your system in the last day or 2, because it could make you sick. Some patients will say they want a medication that works this way because they want the accountability, and they only want to make the decision once a day not to drink. They want to wake up, decide in the morning to be sober that day, and then not have to decide throughout the rest of the day or in the evening when they might experience more severe cravings, because they know if they've got this medication in their system that they can't drink or else they'll get sick. What do I mean when I say if you drink alcohol on this medication, it'll make you sick? I mean, it can make you violently ill. You can have horrible headache, chest pain, nausea, vomiting, difficulty breathing. And because of that, it's really a medication that we avoid and don't use too much of these days, particularly in patients who also have heart disease, lung disease, liver disease, or significant psychiatric or mental health disease, like a history of any psychotic symptoms or a psychotic disorder. This medication can also have side effects even if you don't drink alcohol while you take it. Some patients will develop a funny taste, a metallic taste in their mouth. Other patients might notice some headache or a rash. And so in general, this is a medication that we don't use as frequently to treat alcohol addiction anymore. And recently, in my experience, a number of pharmacies have actually had difficulty keeping it in stock. But it is an option and could be considered for specific patients. All right, we'll switch gears here. We've talked about medication for alcohol use disorder. Now let's talk about medication for opioid addiction or opioid use disorder. We also have a couple of tools in our toolbox here in terms of medications. The three that we think of most commonly are called buprenorphine, methadone, and naltrexone. They work a little bit differently, and I'll go over some of the specifics in a minute. But what you should know is that they're all effective medications to treat opioid addiction. And it doesn't matter whether a patient's addiction is to pain pills like Vicodin or Percocet or other opioids like heroin. All of these medications could be considered as effective treatment. Another thing to point out here is that these medications are safe and effective to take in the long term. I've got patients who have been on buprenorphine to manage their opioid addiction for 20 years, and they've done well. They've been stable. Some patients would prefer to only take medication to treat opioid addiction for a shorter period of time. And there are pros and cons to that decision about how long to continue medications. Let's start with buprenorphine. So buprenorphine is what we call a partial agonist, and that's a scientific term, but it means that there's what we call a ceiling effect for buprenorphine in terms of how it works in the brain. So buprenorphine binds to the same places in the brain that other opioids like morphine and heroin and fentanyl and oxycodone, it binds to the same places that those other chemicals bind to, but it works a little differently. You can sort of think of it like the burner on a stove. So if you've got oxycodone or heroin or a stronger opioid, that opioid is going to turn the burner on all the way up to high. And when you turn the heat all the way up to high, that's what causes patients to feel intoxicated and euphoric and to feel high. It's also what causes the risk of overdose and death. Buprenorphine acts differently. Buprenorphine turns the stove on, but only to like low or low medium level. And just no matter what dose of buprenorphine we use, we never turn it to medium or high heat. So buprenorphine is much safer, and the risk of overdosing or developing a euphoria or getting high from buprenorphine is next to zero. But because it does turn the burner on the stove on a little bit, it's really effective at helping to reduce or even eliminate cravings for opioids or withdrawal symptoms from opioids. Buprenorphine comes in a number of different formulations. The most common form that we prescribe is a brand called Suboxone. And this is a combination of buprenorphine with another medication called Naloxone, which is actually another opioid blocker, but it's just put into the medication to prevent people from misusing it. Suboxone is available as a tablet or as a film or a strip that you dissolve under the tongue or in the cheek. Zubsolv is a similar brand name, different pharmaceutical company, so the dosing is a little bit different, but it's otherwise the same combination of buprenorphine and naloxone. We don't use Zubsolv as commonly. The vast majority of our patients on buprenorphine take Suboxone, but some folks have an insurance policy that requires them to take Zubsolv rather than Suboxone. A third formulation that we sometimes use is called Subutex. That used to be the brand name, but now we just refer to it as the mono product because it's just buprenorphine. It doesn't have the naloxone in there. So we really don't use that as often, and most patients aren't going to notice any difference in terms of effectiveness or side effects taking Suboxone. So there's almost always a reason to prefer Suboxone rather than Subutex. But Subutex is also available as a tablet that some patients may prefer. The final formulation that we'll sometimes use of buprenorphine for those patients who don't like to take a medication every day, don't like to dissolve a pill in their mouth every day, is a long-acting injection. And the brand name for this is called Sublocade. So this is an injection that you get in the skin. It slowly releases buprenorphine over a period of about a month, but it's the same medication and it works in the body the same way. We don't provide Sublocade in our clinic, but there are a number of clinics locally in Ann Arbor and throughout the state that do offer Sublocade, and we're happy to refer patients to those clinics if they're interested in learning more about Sublocade treatment. That's buprenorphine, and the other opioid that we'll use to treat opioid addiction is called methadone. This is also an opioid agonist. It binds to the same place in the brain as buprenorphine and other opioids like Vicodin and Percocet and heroin. It's a long-acting opioid. So you take it once a day, typically in the mornings, and that helps to ward off withdrawal symptoms or cravings throughout the day. There is not a ceiling effect on this medication. So this one has the potential to turn the heat a little bit higher on the stove. And because of that, there needs to be just some more supervision for patients who are treated with methadone. It's not taken as a tablet or as a strip that dissolves in the mouth, but it's taken as a liquid that you swallow, typically once a day. I'm not actually able to prescribe methadone for the treatment of opioid addiction. This is a medication that's regulated, and there are specific rules about how this medication can be dispensed. So I can't write a prescription that a patient can take to their pharmacy or CVS and fill the prescription for methadone, but there are specialty clinics, sometimes referred to as methadone clinics or opioid treatment programs, OTPs, that dispense methadone once a day for patients who are on methadone treatment. So you may be wondering, do these medications work for opioid addiction? Like, are they effective? And the answer is tremendously, they are effective. We know that patients who are treated with buprenorphine or methadone for opioid addiction are less likely to overdose, less likely to die, less likely to relapse or return to using opioids, less likely to be arrested, less likely to develop infections related to injection drug use like hepatitis C. So the list of benefits of this form of treatment with buprenorphine or methadone is really long. It's specifically been shown to be effective in the population of pregnant women who have opioid addiction, both in treating mom as well as helping stabilize things so that baby can be born in the most healthy way. What I will describe to patients is, say you take 10 folks who have an opioid addiction, they're using pain pills, they're using heroin every day, they've been using every day for a long period of time, they have an opioid addiction, and you take all of those 10 patients and you put them in the hospital or you put them in a rehab facility, and then you discharge them. And if you discharge none of those 10 patients on buprenorphine or methadone, then 3 months later, we would expect, just based on what we know about the nature of opioid addiction, the fact that it's a relapsing illness, we would expect 9 out of 10 folks to have returned to use with opioids without medication treatment. In contrast, say you take 10 other patients who use opioids every day, who have an opioid addiction, who are hospitalized or who are admitted to a rehab facility, and you start all 10 of those patients on buprenorphine or methadone, then that number who will relapse drops from 9 down to like 4 or 5. So it's not a magic bullet. We know that some patients treated with buprenorphine or methadone will still relapse, but it's tremendously effective at reducing that risk. And again, that effect is due to these medications' ability to help treat symptoms of opioid withdrawal and cravings for opioids. So when we treat patients with buprenorphine or methadone, our goal is for those patients to just feel normal. We don't want them to feel high or intoxicated or euphoric or sluggish or sedated. But we also don't want them to feel irritable and restless and jittery and anxious because they're still having withdrawal symptoms or they're still having cravings to use. So we know that by managing cravings and withdrawal symptoms, particularly with opioids, that we can greatly reduce a patient's risk of returning to use or relapsing. The third medication that we have for the treatment of opioid addiction is naltrexone. And as I mentioned earlier when we were talking about alcohol use disorder, naltrexone is an opioid blocker. So it works in the same part of the brain as buprenorphine and methadone and heroin and fentanyl and Vicodin, but it doesn't turn the stove on at all. It blocks it. Because of this, naltrexone doesn't offer any benefit in terms of suppressing cravings or helping with withdrawal symptoms, but it can potentially block an overdose if a patient is taking naltrexone and then uses heroin or then takes other opioid pills. The naltrexone will block the effects of the other opioids. So this is not an opioid in and of itself. It's not a controlled substance. It's not addictive. You don't get withdrawal symptoms if you just stop using naltrexone cold turkey. But some patients really prefer to have that benefit of reducing cravings and reducing withdrawal symptoms, which naltrexone does not offer. Naltrexone, as I mentioned, for alcohol use disorder, comes in a tablet and oral formulation, but for patients with opioid addiction, we really prefer the long-acting injection that you get once a month. And that's one that we do offer in our treatment, in our clinic at UMATS. Okay, we've talked about alcohol, we've talked about opioids. Let's talk about cannabis. This is a substance that you can purchase legally here in the state of Michigan, but some patients will develop difficulties from their cannabis use. They'll develop a cannabis addiction or a cannabis use disorder. Unfortunately, we don't have good FDA-approved medications for the treatment of cannabis addiction or cannabis use disorder the way we do with alcohol and opioids. There are some medications that we've studied, but there's not a ton out there that's been really proven to be effective. One medication that we sometimes will try and sometimes will offer patients is actually an over-the-counter supplement called N-acetylcysteine or NAC. This is an amino acid. Like I said, you can get it over the counter. There's some evidence that this is a really effective drug in helping to reduce drug-seeking behavior, particularly with cannabis in animal models. There have been some studies that suggest that NAC, N-acetylcysteine, helps reduce the risk of relapse and helps with cannabis cravings in adolescent patients who have been able to stop using cannabis. But the evidence is less compelling for adults. It's really safe. There's really few side effects. There's essentially no downside because it's so well tolerated. So we're happy to monitor patients if they're interested in a trial of this medication, but we can't say that there's really strong evidence that it's gonna help reduce their risk of relapse on average. Some patients prefer to just go to the pharmacy or order this substance online. Sometimes we can write a prescription for it, and that way their insurance will cover it, and we're happy to do that. Now, what about nicotine or tobacco treatment? We know that nicotine is highly addictive. We know that patients use tobacco products in a number of different forms, whether they're using electronic cigarettes or vape devices, or cigarettes or cigars or chewing tobacco. We know that a lot of patients who use some form of nicotine want to quit. We also know that if you take 100 patients who are using nicotine or tobacco and they all try to stop cold turkey, only 2 or 3 are going to be successful because nicotine is that highly addictive. But we've got some good tools in our toolbox to treat tobacco addiction or nicotine addiction, nicotine use disorder. Some of our options include nicotine replacement, which is giving the body the same chemical, the nicotine, that you would otherwise be inhaling through the cigarettes without all of the other toxins and harmful chemicals that are in that smoke. We use long-acting nicotine replacement in the form of a patch that goes on the skin, as well as short-acting nicotine replacement when you have cravings during the day, gum, lozenges, even nasal sprays or inhalers. And we know that this combination of long-acting and short-acting nicotine replacement can be an effective way for patients who are interested in stopping their tobacco use. We also have prescription medications, including bupropion and varenicline, which work a little bit differently, but can be even more effective than nicotine replacement for patients who are motivated to stop their tobacco use. So we've got some multiple tricks up our sleeve. And what we have found is that the most effective combination is using medication for tobacco addiction, nicotine addiction, as well as behavioral therapy or specific counseling. So who are we? What sorts of treatment services do we provide at our clinic? We are the University of Michigan's Addiction Treatment Services. We're known as UMATS. We offer medication evaluation, we offer consultation, we offer medication management for patients who have just addiction, just a substance use disorder, or who may have addiction and a substance use disorder, as well as a co-occurring mental health condition. We're a multidisciplinary team, so we have physicians, we have nurse practitioners, we have residents, psychiatry residents who rotate in our clinic to learn about addiction treatment. We also have licensed therapists and licensed clinical social workers, as well as nursing staff, because we find that working together to develop comprehensive treatment plans for patients allows our patients to be most successful. We will prescribe medications for addiction treatments, as well as other medications for mental health conditions like anxiety, depression, and that sort of thing. But we also know that not all patients who have addiction need or may even benefit from medication. So we always try to tailor our treatment recommendations based on what our patients' goals are in their recovery. We do believe firmly that all patients who are interested in addiction treatment should have access to it, and that includes access to medication treatment. We see patients who are adolescents, we see patients who are adults, and we welcome any patients who are interested in learning more about their addiction, maybe think they might want to make a change with their substance use, maybe are interested to learn about treatment options. We would welcome all patients to schedule an appointment with us so we can describe all of the treatment recommendations that we can offer. We see patients who have most private insurance, and we also see patients who are covered by Medicare as well. Many of our patients are receiving care through telehealth right now, and that's been something that we've done throughout the COVID pandemic. But in some circumstances, we're happy to accommodate patients whose preference would be to be seen individually in person. We offer group therapy at our clinic. Currently, most of our group treatment is virtual or online, but we also offer individual therapy and individual appointments with a prescriber for medication management. What medications do we prescribe at our clinic for addiction? Well, just about all of them that we've covered here, with the exception of methadone. Because as I mentioned, methadone, due to federal regulations, is a medication that can only be dispensed at specific clinics. So that's not one that we're able to prescribe, but for patients who may benefit from methadone treatment, patients who are interested in methadone treatment, maybe patients who have been on buprenorphine and have not found it to be particularly effective and may need methadone, we're happy to refer those patients or to connect them with a methadone clinic. We're also happy to evaluate patients to offer a trial of medication treatment for addiction. And if things go well and the patient feels that their addiction is stabilized and more under control, most primary care doctors are becoming more and more comfortable managing many of the medications that we have discussed today. So we are comfortable linking our patients back to their primary care providers in the community or within Michigan Medicine to allow the primary care doctor to take over the management of those medications in the long term. In terms of additional services that we provide, we offer mainly outpatient treatment. And for those of you who are interested or familiar with the ASAM levels of care, the American Society of Addiction Medicine, we offer outpatient care going from level 1 up to intensive outpatient care, which would correspond to a level 2.1. We do comprehensive assessments, we offer consultations, we offer cognitive behavioral therapy, motivational interviewing, one-on-one individualized counseling and behavioral treatment. And we also will encourage patients to explore mutual help groups such as 12-step programs in the community as well as a menu of group therapy options that we offer and that we run in our clinic. We offer dual diagnosis treatment, as I mentioned, for patients who might experience addiction, as well as a co-occurring mental health condition like depression or anxiety. So that is the summary of our treatment services and the medications that we offer for addiction treatment. I will stop sharing my screen now, and we'll look forward to responding to questions from the audience.
Hi, sorry about that. So thank you, Dr. Coleman. That was really interesting and informative. We do have some questions that we'd like to go through to get more context and information on the things you've been telling us. So just to start off, I was wondering, here, let me just summarize here. One question is, how difficult is it to stop using these medications?
That's a really good question. And the answer is it sort of depends on what medication we're talking about. So the medications that we mentioned for alcohol use disorder, Naltrexone, Acamprosate, those are the sorts of medications that aren't addictive. They're not controlled substances. If a patient finds that they don't feel that medication is beneficial or helpful in their care, they can just stop it. There's no need to discontinue, there's no need to taper the medication down gradually over time. Most patients aren't going to experience any withdrawal symptoms from discontinuing naltrexone or acamprosate. But it's a different story with buprenorphine and methadone. And because these are opioids and they do act in the same region of the brain and they still do turn the heat on the stove on a little bit, patients who discontinue buprenorphine or methadone, they will experience some withdrawal symptoms that are very similar to withdrawal from other opioids. And so we view the treatment of opioid addiction with buprenorphine and methadone a little bit differently. We typically recommend, once patients have been able to stabilize on these medications, to continue these medications. And we view them as treatments, medication treatments for chronic illnesses, the same way we view blood pressure medication for patients with hypertension, or insulin for patients with diabetes, or asthma medications for people with asthma or other breathing conditions. So generally, we recommend patients to continue buprenorphine or methadone long-term, but there are cases where patients may feel like they're ready to gradually come off of these substances. And if we feel that it's safe and that their recovery environment is stable, that other aspects of their life are providing stability for them, then we can gradually go down in a supervised way to minimize the risk of withdrawal symptoms.
Great, thank you. Another question that we got was about availability of these medications in jails or prisons, or for people who are incarcerated.
Yeah, that's a great question. And that has been a concern that's raised by many folks who are aware of the disproportionate rates of addiction and substance use disorders in the incarcerated populations. Historically, the answer has been that patients with opioid addiction do not have access to buprenorphine or methadone in jails or prisons. That's slowly changing. There are some states that are now requiring that those medications be available, but the ball is moving slowly. There have actually recently been some federal regulations to move us more in that direction. But for opioid addiction, specifically across the board, historically, these medication treatment options have not been available.
Thank you. So question we had was around medications for addiction in individuals who also have co-occurring attention deficit hyperactivities, ADHD, ADD diagnoses, um, how the medications may work, or how there's maybe some joint treatment for people who have both, particularly adults who have both.
Yeah, that's a great question. And that's something that we see commonly. We know that ADHD, particularly when it's severe, can really interfere with functioning. And ADHD, when not treated, can interfere with patients living their life at the quality that they wish to live it. We know that stimulant medications can be effective treatment for ADHD in some cases. These are medications like Adderall, amphetamines, or methylphenidate, Concerta. But we also know that patients with addiction may be a little more vulnerable to other psychoactive substances like stimulant medication. And the biggest concern is patients who have ADHD, but also have a stimulant use disorder and are using other stimulants like cocaine and methamphetamine. In general, we won't prescribe stimulant medication if we know patients are using illicit stimulants like cocaine, methamphetamine, because it's unsafe. You have a risk of heart attack, you have a risk of other toxicities, and there's just a risk of harm. But for patients who might have alcohol addiction or opioid addiction and have never misused cocaine or other stimulants, and who have demonstrated that they're able to take stimulant medication responsibly, we have a number of patients in our clinic whose ADHD we treat with stimulant medication and whose opioid addiction we treat with buprenorphine.
Great, thank you. And someone is wondering, for younger patients, what the long-term treatment plan is. For example, if someone is using buprenorphine or methadone, for younger patients, like, is that something that would take place for many years, or is the treatment plan different?
Yeah, that's a great question. That's something that we're still learning more and more about. So buprenorphine was FDA approved in the early 2000s. So we don't have decades of research to understand how folks do over time and whether there are any long-term risks that you might develop if you're continuing buprenorphine treatment for 20 or 30 years. What we know and what we prioritize is treating the opioid addiction here and now. So if an adolescent patient is using opioids or heroin, particularly patients who have had multiple overdoses, their risk of death is high. And our priority is to keep them alive. So we feel that treating with medications for opioid addiction here and now to stabilize things is priority number one. And then as those patients age, some patients might grow up 20s, 30s, 40s, get married, have stable jobs, and feel like they're in a really stable place in their life to gradually discontinue the medication. And that's something that would be reasonable and something that we work with patients for. But to answer your question, I wish we had more data about long-term effects of young patients and adolescents who were treated with buprenorphine and methadone.
Thank you. So someone else is wondering, this isn't exactly a medication question, but I think a really common question that we are asked, which is about how families who want sobriety for their loved one, but the loved one does not want treatment or help, how can the family member handle that, whether that's Al-Anon or detachment or other ideas? And I'm happy to chime in as well, but what are your thoughts?
Yeah, that's a great question. And so many of our patients and so many of our patients' family members and partners have been in that situation. What we know is that people's readiness for addiction treatment can fluctuate. And there can be certain situations that might make them more or less willing to consider seeking treatment. One situation that we see commonly is for families to stage an intervention of sorts, for everyone to sit down with a loved one and say, hey, we're really concerned. This is the way that your substance use is affecting us. We're concerned about your safety, and it would mean a lot to us if you get help. So it's an old-fashioned approach, the family intervention. Sometimes it does not go well. Sometimes the patient storms out of the house, but sometimes that can get folks' attention, and that can be enough to persuade them to make an initial appointment and to learn more about their options. So I think that having family support is integral for patients who are ready to seek treatment, and sometimes having family members raise their concerns and convey that in an empathetic and compassionate way, sometimes that can be effective. But Dr. Fernandez, I would welcome your input as well.
Yeah, I definitely agree with what you're saying, that families can have a really important role in helping people engage in substance use treatment, even when they may not be initially ready. And there are different ways to do that. There's also different ways to cope with your own emotional experience that you're going through as a result of living with someone with a substance use problem. So one thing I do recommend, and Al-Anon is a 12-step organization that can be helpful for people. It is a little bit more of a detachment focused model of, that you can't control someone else's substance use. But I do think there are things that you can do. You can get help for yourself, for example. So regardless of what someone who has an addiction is, what choices they're making for themselves, you can make a choice to come in to get treatment yourself. Even our clinic, for example, has a family and friends group where the identified patient is actually the person who's affected by the substance use of a loved one. And then you could get a professional clinician's opinion on things that you can do, maybe things that you shouldn't do in trying to approach or talk about addiction with your family members. So that's something you can do even on an individual basis with our clinic. And I do think communicating with the person with the substance use issue is really important. And that may include sometimes a more organized family intervention, which I think can be effective if it's loving concern and, is delivered in the right way, often with some professional guidance. And I also think it's really appropriate to set limits with people, especially where safety is concerned. So if this is someone caring for other family members, to set appropriate boundaries and limits around what's safe, driving, childcare, things like that. So yeah, I really encourage anybody to get help through organizations or through clinics, even if the loved one isn't willing to go, to support yourself and find out more about what you can do. So, but that's a great question and a very, very difficult thing that many people are experiencing. So this is, so one question, I don't actually know the answer to this, Dr. Coleman. I don't know if you've heard anything about this, but someone is wondering about the research, if there's any research on hypnosis with addiction and medications and any combination of those things. I'm not really aware of any. I know kind of for smoking cessation, I hear of hypnosis being used sometimes, more anecdotally, but I don't know if you're aware of anything.
Yeah, that's a good question. I'm not aware of any peer-reviewed literature that really looks at the combination of hypnotic therapy or hypnosis with other medications. So that's not something that I'm trained in. That's not a treatment option that we have experience delivering.
Yeah, thank you. And an additional question is about insurance coverage for medication-assisted treatments, if it's covered usually, or if not, is it very expensive?
Yeah, that's a good question. And this is something that patients ask a lot. Most of the medications that we mentioned are covered by most insurance companies. There have been some changes after the Affordable Care Act related to the regulation and requirements for health plans to provide addiction treatment on par with other medical treatment or other surgical treatment. So most of the medications are generally covered. Many patients find that they will have a copay. Many patients will find that their insurance plan might recommend or require one formulation of a medication over another. So for instance, some patients have to take Zubsolv rather than Suboxone. And very few insurance plans will cover Sublocade, the long-acting buprenorphine injection. So that's one that if patients are interested in it, most will pay cash out of pocket. But most of the basic medications, most formulations of buprenorphine, certainly Naltrexone and Acamprosate, are typically covered by Medicare. Many state Medicaid plans will cover these substances, these medications as well. And all insurance companies are required to provide coverage for tobacco treatment.
Thank you. And I'm sorry, I'm just scrolling through these questions here. So there is a question about psychedelics being tried as a treatment for addiction, which I know is becoming a more and more common topic in the media and in research, but really well publicized. So someone's just wondering about kind of what we know about that research literature, but also if UMATS is involved in these trials. I can say for the latter part, UMATS is not involved in these trials. They're very controlled. These are federally regulated substances, and these research trials are taking place in really particular places. UMATS is not one of the places that's doing that, and it's definitely not being done clinically here at this time. But I don't know, Dr. Coleman, if you know much about that, some of the ongoing research in that topic area.
Yeah, no, it's a great question. It is a hot topic. There has been more interest in these sorts of research questions. Johns Hopkins is actually one of the leading institutions that is studying the use of psychedelic substances for the treatment, not only of addiction, but also of post-traumatic stress disorder and severe depression that has not responded to other forms of treatment. So my short answer is stay tuned. We're learning more and more. There's certainly not enough evidence for me to recommend the use of psychedelics or folks to go microdose themselves, because there is definitely a risk of harm. But I think that we may be learning more about some potential benefits in specific patient populations. So this may be a form of treatment that is offered 10, 15 years down the road as more research is done.
Yeah, thank you. And one additional question is around the controversial role of medication-assisted treatments in the recovery community. You know, in some ways, they're really widely regarded as a really wonderful part of recovery, and in other areas considered not recovery at all. So any thoughts about why that controversy exists?
Yeah, this is a tricky one, and this is a conversation that I have with patients often. Some patients really are insistent that they don't want medication treatment. Many folks feel that they're just substituting one drug for another. They're substituting buprenorphine for heroin. And some recovery communities have an abstinence-based approach or an abstinence-only policy. My point of view really comes from the data and what we know about the effectiveness of these medications. And we know that some patients, even with opioid addiction, 1 out of 10 patients can do well and can not relapse, even without buprenorphine or methadone. But a majority of patients are likely to return to using. And we know there have been numerous studies that show that these medications can help reduce that risk. So the conversation that I have with patients and the way I try to frame it is that we're treating a chronic condition that you have. You have a substance use disorder. We're using a medication that's been studied and regulated, that I'm monitoring, that I'm prescribing, and you're in a clinic. And if you're able to stabilize on that medication and a lot of the other aspects of, or the consequences of addiction in your life when you were using regularly, if we're able to get all of those things addressed, then you don't have those addictive behaviors anymore, but you're just benefiting from medication treatment for a chronic illness. The same way many patients use insulin to manage their diabetes. I often will tell patients, because I come from the world of primary care, if I have a patient who's using insulin and we just stop the insulin, what's going to happen? We know the blood sugar is going to go up. We know the diabetes is going to go out of control. And so There has been a lot of stigma through the years to view addiction differently, but it's really a chronic illness with a number of similarities.
Thank you. Another question is, should I keep Narcan in my home if my family member is in recovery from opioid addiction?
Yes, yes, absolutely, you should. We try to prescribe Narcan or make Narcan available for all of our patients, whether they are in recovery from opioid addiction themselves or whether they have a loved one who is struggling with opioid addiction. We know that opioid overdoses happen. We've all seen the news. We know the numbers of the opioid epidemic. We know that opioid use is even more deadly now in the last couple of years than it was 10 years ago, because of the amount of fentanyl that people are exposed to, sometimes without even knowing it. So the risk of overdose is elevated just in the general community. We know that Narcan is a really safe and effective way to reverse overdose and to keep people alive. And we know that some patients who are even on medication treatment for opioid addiction may return to use and may relapse. And what we want to do is keep them alive so they can re-engage in treatment. So yes, if you have a loved one or a family member who is struggling with opioid addiction, we absolutely want you to know how to use Narcan, to be familiar with it. And if you don't have it, let us know. We can connect you with places where you can get it. You don't even need a prescription. You can walk into any pharmacy in the state of Michigan and pick up Naloxone or Narcan. Many health departments will distribute it as well. Great question.
Okay, thank you so much. We're at 7:58, so we're just wrapping up. We got to a lot of questions, but if we didn't get to your particular question, I apologize. Hopefully you can get your answer or reach out and get your question answered. And just in a brief closing, I just wanted to share our thanks for your attendance and for your engagement and questions. They were wonderful to have engagement from the community and participate in this way. We hope you found this information helpful that we've shared tonight, and we provide a couple links in the chat, including our research page, our clinic, and information on our next session, which is going to be on May 11th, 2022 from 7 to 8, focused on family and addiction, how families and friends can get help and support for a loved one with addiction. So that could be of interest to some of you who ask questions about getting help for loved ones as well. So with that, thank you, Dr. Coleman, and thank you everyone for attending and for to the organizers for organizing, and we hope to see you next month. Thanks so much.